Just let Lynn set up the final touches here. Ready for you, Ian. So welcome everyone. I guess this is our second CHEPA seminar. You'll be seeing a lot of me up here, unfortunately, for the remainder of the year because I'm helping organize the sessions. And one of the good things about that is I get to meet new people and new people at the university, like Dr. Gorter here, and introduce them to the talk at CHEPA seminar. So Dr. Gorter is a professor of pediatrics in the School of Rehabilitation Science here at McMaster. He holds a Scotiabank Chair in Child Health Research. He's an adult trained psychiatrist, developmental disability specialist. He also has a special clinical and research interest in transitional services and lifespan. He leads a teen transition clinic for teenagers with cerebral palsy and developmental disabilities and their families at McMaster Children's Hospital here on campus. He also leads CanChild, you can see the emblem up here on these slides, which is a world-renowned center of excellence in childhood disability research with a global network. And he works with a number of undergraduate and graduate students here at McMaster University and universities in Canada, as well as in the Netherlands. He's a co-author or author of more than 110 peer-reviewed publications and books and journals about cerebral palsy, transition to childhood, sexual development, and health. So would you help me welcome Dr. Gorter?
Good afternoon, everyone. Thank you very much for the nice introduction, and thank you, Michelle, for the opportunity to speak here at CHEPA. Before I go into my topic and show you some of the research we have done and we are planning to do at CanChild, I'd like to give you a little bit of background about our research group CanChild at McMaster University. So we are celebrating our 25th anniversary year this year in 2014. CanChild was founded by Dr. Peter Rosenbaum, here in the slide, as well as Dr. Mary Law, a professor in the occupational therapy in School of Rehabilitation Science 25 years ago in 1989. At that time, CanChild was not named that way, but later on, one of the parents suggested that the group should name itself after CanChild, reflecting what children can do instead of what they cannot do, which was a very positive message, and we'd like to continue that. We had a nice celebration on June the 23rd with the leadership of both the university and the hospital, as well as with the children and the families. As I said, this is a celebration here, it's not one event, and we're looking forward to another event on November the 22nd here on campus in the CRC Hall with what we call a family engagement day, really to make the connection with families and to find out what they find important and what is relevant to them and how they would like to work together with researchers as part of our strategy. So you can find out more information on our website as well as on Facebook and on Twitter. So to give you a little bit of background what we do at McMaster University for 25 years, and we're planning to continue that for another 25 years at least, is to take a leadership role in identifying emerging issues for research, practice, policy, and education. And we really do that with the stakeholders, conduct high-quality programs of research, and in particular, I sort of highlighted the program of research rather than single projects, but really to see where are we coming from, where are we now, and what are we going to do next. We take pride in professional education of students that will help to build capacity, the new generation of researchers in the field of childhood disability, and more broadly, child health and development. CanChild is also known for a knowledge translation program. I think CanChild had a website at the time that research group didn't have website or started to find out what the website could do. Now, of course, everyone has a website, and we're working now with the social media as well as, for example, on a Facebook page with the parents to engage with them and to find out what research means to them. It was shared in the introduction that we partner, we are housed here at McMaster University, but basically the children, youth, and families are at the center of everything we do at CanChild. And you can see that throughout the program of 25 years of research that parents have always been involved in not only as a participant in research, but also in designing research studies, as well as co-creation of tools that are helpful, for example, in helping to raise a child. Healthcare providers and organizations and the educational system, schools are other stakeholders. Also government decision makers. I'll show you an example later on some work we did with the Ministry for Children and Youth Services. And last but not least, we are a network of researchers and university educators throughout more at the national level, as well as worldwide connections. And my background is Dutch. I'm from the Netherlands, and I did a postdoc at CanChild. I was one of those trainees in 2002. Went back to the Netherlands and founded NetChild as a spin-off of CanChild, and ended up here at CanChild now in the network. And as you can see, the network is much broader than the Canadian-Dutch connection. More connections in North America, Europe, and Australia. And our co-founder, Dr. Peter Rosenbaum, just returned back from a few-week stay in Australia for a lot of teaching and research collaboration. But closer to home, I don't know if you are aware, but we are actually neighbors. And I thought it was important to mention that we are, McMaster campus is big, but we are just next door in the building, the Institute of Applied Health Sciences, where the School of Rehabilitation Science is housed. So the physical therapy and occupational therapy program runs, as well as rehabilitation science. And our team reflects many backgrounds, multidisciplinary team, including pediatrics, occupational therapy, physiotherapy, kinesiology, rehab medicine, also mentioned as society, speech and language pathology, social psychology, epidemiology, and biostatistics. And also I know there are connections with health economics here at CHEPA in different projects. Our expertise is really, if you look back and where we are now, is in developing outcome measures and making sure that we have outcome measures that are reliable and valid and are useful for healthcare providers and for families. Longitudinal and clinical trials research. That was started up at a time that there was hardly anything known about developmental trajectories of children and youth with disabilities. So CanChild really took a sort of leadership role in that. We have expertise in both quantitative and qualitative analysis, as well as integrated knowledge translation expertise. So today, and I can say that we have grown a lot, and basically we have 19 scientists that are more or less housed here or closely linked to McMaster. And then there is a wider group of associated scientists. In 2015 there were 37, and it has grown to in total over 60. 5 postdocs are currently working at CanChild and 15 PhD students. Last year we were successful in 42 grants, totaling 10 million and 2.5 million through the School of Rehabilitation Science. And if you look over the lifespan of CanChild, a total of 47 million, and last year 180 scientific publications. So I think we are a productive group, and we like to do research, for sure. So let me move on after this introduction to one of our research themes, and that is really an interest in how children and youth with disabilities grow up and how we can best support them if there are any challenges. One of the challenges is that children with childhood-onset conditions now survive into adulthood, and they make what we call the transition in many ways in life. For example, you leave high school at some point, but you also make a transition in the healthcare system from the pediatric services to adult healthcare services. And that comes with numerous challenges, and I'll show you a few of them. So my objectives for this talk are to discuss critical gaps in our understanding of developmental trajectories of these youth. And I think the knowledge is critical and essential to inform evidence-based healthcare, but also policy and decision making. And I think talking to and working with ministries and policymakers, I see a huge appetite and interest in that knowledge. They really like to build and develop programs based on the knowledge that's out there. I also like to discuss with you ideas how we could improve lifespan health and transition to adulthood, and how we, and maybe more for discussion, some ideas how we can measure and improve physical and mental health status for young people and their families, as well as the burden of growing up with a disability. So as I said, children and with onset disabilities, the good news is that now advances in medicine and community care have really increased the survival rate, and basically over 90% of the children become adults, which is a success, and they are living out there in the community in need sometimes of support and resources as well as healthcare. For example, in the States, we talk about a significant number of youth transitioning from the pediatric to the adult healthcare system, 500,000 adolescents with disabilities. And if you look back and look at some of the development of medical care for a couple of conditions, but they are very parallel and very similar to other conditions, is that if you see that since the 1970s, we see that children with child-onset conditions like Down syndrome or spina bifida or congenital heart disease starts to survive into adulthood, so over the age of 18, which is the orange bar. And in fact, as this is all growing, we now have more adults with child-onset conditions than children with child-onset conditions. So if we translate it, and we recently looked into it, and we don't have actual data on the national level in Canada, but we estimated that we can talk about 1.3 million people with those child-onset conditions into adulthood. And if you look at U.S. statistics, if you take it even broader to all disabilities, we talk about 40 million, close to 50 million people, and I would think that you can sort of do the math what that means for Canada. So all these people with child-onset conditions and the families go through a process that we call transition. Basically, it's a process of growing up ready for adult life, which applies to all of us, right? But for children with child-onset conditions, it comes with an extra challenge. At some point, there's a transfer of care, and at some point in time. And here in Ontario, it's very specific that at age 18, by the mandate of the Ministry of Health, you have to leave the children's hospital. And sometimes you see it in the news that there are some issues that parents and families leave the children's hospital and try to find a way in the adult healthcare system and don't get the services they need. Ideally, and that's not new, Bloom in 1993 already published a seminal article on the notion of transition being a process, not at one point in time, but a purposeful planned movement towards transition to adult health-oriented services. That's not the reality. This is what the literature is telling us, and we know it's both from anecdotal and from other studies, as well as I can tell you and speak to it as a clinician for my clinic. We're still dealing with challenges in terms of transition. The transitions are ineffective. They lead to costly hospitalizations, inequity of healthcare services, and a possible lifelong economic burden to the family and society. I give you a few sort of snapshots of different conditions, and this is across the board. So sometimes it's thought that yes, children with disabilities there's more complexity to it because it can impact not only, for example, the way your mobility, but also self-care activities, maybe intellectual challenges and other needs. But if you look at, for example, a condition like diabetes, we also see the same pattern that leading pediatric care is associated with an increase in poor glycemic control, which leads to complications. Same thing for children with a kidney transplantation. In the years after transfer of care to adult care, there was a huge increase in unexpected graft loss. And cancer mortality. From a specialist in cancer research, I understand that that is the age range 18 to 25 years is the most critical age and highest mortality rate relative to the population. I work a lot with as a psychiatrist with children, teenagers with cerebral palsy, a condition that is due to an injury to the developing brain early in life, that can be before or during or shortly after birth, and is defined by a problem by moving around, and can also come with other challenges. And my interest is what happens to adults with cerebral palsy after they leave my teen transition clinic at age 18. Well, we have some data from in Canada, and more specifically in Ontario. So one of our colleagues, Nancy Young, looked into OLIC data and was able to identify healthcare utilization patterns for youth in the youth before transition, age 13 to 70, and the young adults, age 23 to 32. And she looked across severity levels, so youth with individuals with cerebral palsy who are able to walk versus the ones who may need a wheelchair to get around. Of course, there were OLIC data, so it doesn't speak to all the services and supports these individuals' needs, but limited to assistance and hospitalization. She found that compared to the general populations, these people were admitted more often, 7 times, and if they were admitted, they required more days and stayed more days in hospital. The youth were more admitted than adults. Another interesting finding was that in adults there was an increase in mental health issues and the use of mental health care that I wasn't so much aware of before I read this paper in 2011. She also found that these utilization rates were found not only in cerebral palsy, but other similar conditions like spina bifida and acquired brain injuries. And it's not only here in Ontario, but very similar to patterns found in the US as well. So in conclusion, in a discussion, she speaks to that there are few adult-oriented health services, that general practitioners, family doctors can play a role but need resources, and that the access to specialist consultation is an issue. This comes with a cost, and I actually involved as a co-chair of a working group on transition for the Provincial Council for Maternal and Child Health in Ontario. And we, so at that level, there was really an interest and a push to do something about it and to come up with recommendations across organizations and across the province. And why is that? Of course, because if it doesn't go smoothly, and I showed you the data, medical needs and costs outside of the condition, normal trajectory may be increased. And we think of, as I mentioned, the increased visits to the emergency departments, increased outpatient visits, and later stay, but also the burden for the families and economic loss. If you spend all that time in hospital, you cannot go to your work. And that's not only for the individual with the cerebral palsy or the childhood-onset condition, but also for the family. So even in this wireless age, transitions can be very challenging. I'll show you a little bit of what we do know, and then I'll go into what we don't know or what we may need to know about trajectories of the youth with cerebral palsy. So when I was in training 15 years ago, there was hardly any reference data in terms of, for the individual child with cerebral palsy, how he or she would develop in terms of his or her gross motor function. So first, CanChild, scientists at CanChild have developed a measure to reliably and validly measure gross motor function. It's called the gross motor function measure. That we presented it on the y-axis. It's an interval scale between 0 and 100. And typically, a typically developing child of 5-year-old would reach a score of 100. So you're able to stand on one leg and to hop on one leg and so forth, and have good balance. Children with cerebral palsy, on average, have lower scores on that scale. And through a study in over 650 children in Ontario who participated in a longitudinal study, we were able to, or the group was able to develop these motor growth curves, which have been very useful in understanding what the trajectories are on average of children in different levels of severity. And these are expressed in the level 1 to level 5. Level 1 being the children who are able to walk and run, where children in level 5 are relying on assistance and need a wheelchair. So this was done in Canada in the 1990s, and then another study in the Netherlands that I was involved in did a similar approach, looking at longitudinal development of children in different categories. And 10 years later, we found similar patterns for the cross-motor curves. Here you see the raw data, all the single dots and the sort of spaghetti curves, as Peter Rosenbaum called them, for each GMSCS level. And you see the red and the blue bar line that are very similar for both the Dutch and the Canadian. So we thought that there was really there was a validity to the measurement and to our understanding of cross-motor development. But there's more to be able to stand and walk and run in life. This was all done in a test situation, so at the therapist clinic, and we want to know also how children actually function, perform in daily life. Okay, I'll show you that later. As a follow-up to the motor growth curve, Steve Hanna, one of the biostatisticians and methodologists at CanChild, probably well known in this group as well, is now involved in a study. It's called the Unchecked study, where because we have the reference data and we have so-called percentile curves, we can now compare and sort of predict what the predicted development rate is for a specific child, and then look and check if they actually develop as predicted, or better than predicted, or lower than predicted, and what the predictors of that of the different sort of trajectories are. And that will give us insight in how potentially we can attune our therapy services to the individual child. Going back to my comment that there's more to life than being able to stand on one leg in a therapy setting. So we also were interested with another measure to capture what the children and youth can actually do in daily life. We call that performance, what they actually do at home, at school, and in the community. Also, this study in the Netherlands, over 400 participants, was done in a wider age range, basically ranging from age 1 to age 16. You see a similar sort of pattern of the graph with a distribution across GMSCS levels. GMSCS level 1 being the top curve in the purple, and GMSCS level with a more severe involvement in very different lower trajectory. And you also see in gray the typically developing curve. So again, these curves represent on average trajectory for a group of children that are characterized by their severity. We want to know, of course, more in detail what predictors are, and typical predictors for cerebral palsy are age, severity, and intellectual disability or cognitive functioning. So that we did additional modeling, and you can see that there is a clear difference in pattern between the individuals without intellectual disability, who have a curve or a pattern that is following very much the typically developing line on average, where individuals with intellectual disability doesn't use discrepancy. And that may be very obvious and sort of understandable, but in our field it's very important if we talk about prognosis and allocation of resources. It's important to know and to have good data. Taking a step further, we also are very interested not only in terms of mobility and self-care activities, but also social participation, again with a similar measure, and we could see different patterns for the ones with and without intellectual disability. And for the group with intellectual disability, on both curves actually, there was a true difference for the ones with more severe involvement. The last study and most recent study I want to share with you is a study done in Europe by Willem Gorter. It's called the Sparkle study. It was just published last week, on October 7th. It was also in the news. It showed two slides, maybe a little bit small. On the left-hand side, you see different domains of the quality of life measure for children with cerebral palsy, and they are in the green. They were all adolescents with cerebral palsy, 400 in total, and the blue bars are the ones of the reference population, the general population. And except for school acceptance and self-perception, there were no differences. So the news that came out was really that quality of there may be huge differences in mobility, and performance, and social participation, but except for self-perception and school acceptance, the quality of life rating by the person themselves was very similar to their peers. The other thing they were able to do was to compare the group of adolescents, their scores with the scores that they had 4 years earlier when they were a younger teenager or a child, and they didn't see much change other than these are the Delft scores for school life, so a similar domain and psychological well-being, and that was very much related to pain and fatigue. So this is information I said earlier that 15 years ago when I was in training, I started my training, we didn't have that reference data at all, and now through longitudinal studies for this population we have learned so much in different life domains how these children, teenagers, and now adults develop. But for the ministry and also for policy making, they want to know, of course, not want to wait 50 years to do this all for every condition separately. They want to know what's the bigger picture here. So in 2010, the Ministry for Children and Youth Services was thinking of developing a youth policy framework, and they wanted to be informed about the pattern of youth with disabilities broadly. And so a common understanding of and language for the developmental pathways in that age range, and also to identify supports and opportunities that they require to make the transition to adolescence and into adulthood. So our knowledge synthesis for the ministry was to synthesize the evidence on these developmental trajectories for youth, and we really looked across conditions, so not only physical, but also developmental, cognitive, emotional, and behavioral conditions. We took an approach based on some McMaster work here, where we could look at the knowledge synthesis, or the knowledge out there in the research evidence, but also wants to include clinical and research expertise, as well as youth, parents, and community expertise. And together, we wanted to present that to the ministry. Through our search, and we were very specifically looking at longitudinal trajectories, at least a follow-up of 2 years, we found only a proportion in actual published longitudinal research. We also found some information on longitudinal trajectories in other more descriptive or qualitative studies. In total, a relative limited number, only 100 articles that were eligible for our criteria for such a broad population. The summary, to give you the summary, we found a paucity of longitudinal data, and we also found that it was very hard to identify outcomes that were relevant to the person. Typically, outcomes that are reported on in adulthood are examples like, are you employed, yes or no? Do you have a job, yes or no? Are you married, yes or no? And so forth. And that is maybe helpful in a traditional sense to have an understanding, but it doesn't contribute necessarily to things like quality of life or social participation. The other thing is that the literature looks very much at risk factors and protective factors, but not into interactions between person and environment. I'll show you that in the next slide. So, as I said, more traditional outcomes were reported on and very normative in nature. So, if you have a norm of having a job, being married, and living on your own, then by nature of the outcomes, these people are growing into disabilities, is an expression that's often used, and they are disadvantaged and have negative outcome profiles from the outside. That doesn't necessarily translate in a poor quality of life or other outcomes that may be more meaningful. In the acquisition of adult tasks, we really have to think of meaningful outcomes. The other thing we found is an interesting finding, what I showed you earlier, that there was more use and utilization of mental health services in adults with cerebral palsy. We saw that across conditions that population-based studies for children with conditions, impairments, with activity limitations are significantly more likely to have mental health issues, which is, I think, important if you think of prevention of mental health issues like depression and anxiety later on in life that you could potentially influence through policy. For example, allowing children to meet with their peers or making playgrounds accessible and so forth so that they can develop a good sense of social interaction. Risk and protective factors. Before 2000, published literature tended to really focus on one or the other and separate personal and environmental factors. And then most of them, and including our own work, as I showed you earlier, the severity of the cerebral palsy and the intellectual impairment are basically more or less fixed to the person. They will not change. So it's helpful to know in terms of risk stratification for services, but not so much to help the individual child and family. Moreover, you can have GMSS level 4. So you basically are, you have cerebral palsy, you have GMSS level 4, you go around in a wheelchair, you can get yourself to places in a powered wheelchair. But that, and in the overall picture is that you are have more challenges in mobility performance, in social participation. And, but that doesn't necessarily say what the outcome is. Yesterday, for example, an individual with cerebral palsy GMSS level 4 defended his comprehensive exam in the School of Rehabilitation Science and is performing really well. So at the individual level, that doesn't say anything. In fact, maybe the fact that he was more dependent on others or had some challenges early in life helped him to get to this point. Interestingly, and I find it very interesting, we have to look into more in detail, is how the interactions between person and environment factors are working out and having impact on developmental trajectories, because I think that's where, both from a clinical perspective and also from policy, there are the points of entry where it can influence. In our knowledge synthesis, this was not so much from the work published, but more from expert input, was that we looked into what were processes at work and what are potentially things that we can influence. The first thing was relationships, so youth, family, and community interactions and relationship building, capacity building in the community can be very helpful to improve outcomes. Also to ensure that a young person has positive experiences and will grow instead of negative experiences and will sort of have a negative trajectory. And then, of most important, especially for policymakers, is of course, what are the supports and the resources that need to be in place to ensure a positive trajectory that children and youth can really excel and sort of do better than the predicted trajectory. We all put that together in a conceptual developmental framework, where you see on the left-hand side the person and the environment are traditionally separate, and in the traditional literature before 2000, studied in different sections. Now, hopefully, coming together and looking at the person-environment interaction. Through the processes of work and influences in leading to improved outcomes. And this is something that was just published in the summer 2014, which I would like to build on our program of research. So both looking at defining what our outcomes are of interest in adulthood, because there are very little out there, as well as where we can influence. And that's what we are currently at in our program of research related to transition, is really to close the knowledge gaps and to see where we can improve the life trajectories. We want to focus on both, not only physical, but also mental health and well-being. I think that's really, and bringing that together. The traditional literature is very siloed, so both pediatric and adult literature is very segregated, as well as physical and mental health issues are also, you read upon it in different journals. We want to specifically focus on what can we do to improve the transition to adult services, because we really have to make the connection between not only in healthcare, between pediatric and adult services, but also in the educational system, as well as the social system. We know very little about adult life issues of this population, and as I've shown you before, we are talking about a huge population, and it's a growing, basically a new generation of individuals in our society. And we want to also look at, because it's the person in the home environment with family, we also want to look at the impact on health and well-being of caregivers. As the young people grow up and become an adult with a physical disability, the parents age as well and are still involved in providing typically care for these individuals. We made a couple of recommendations to the Ministry for Children and Youth Services, and I was very happy to see that they ended up in a policy framework with a really inclusive model, so not to have sort of general youth policy and then also something for youth with disabilities, but they really brought it together. We recommended to really to make sure that there is more focus on, and that the funding goes to programs that encourage and stimulate the person-centered planning, not so much per se to services, to focus on meaningful outcomes, and can think of participation, another topic that has been addressed by our group of scientists, citizenship, engagement, community in contribution to the community, life satisfaction, self-determination, very important, and a healthy sense of self and well-being. You could summarize it as quality of life. I think, and I hope also we have some time for discussion where we can come together, CanChild and CHEPA, is where how we can evaluate these services and models that promote positive youth development and transition. An example is one of our more recent scientists, Mark Ferro, who works at the Offord Center in Psychiatry, as well as CanChild, who is thinking of, who has a special interest in the comorbidity between a chronic physical illness and mental health issues, and vice versa, and approaches to overcome these issues, for example, through family-centered approaches to pediatric health care. Because there is literature out there that if you provide care in a certain way, that it's family-centered and really geared towards that family, it reduces family stress and it can improve outcomes and satisfaction. So the question is, why don't we do it already if we know that it can be helpful? The other thing is that we need to identify targets for intervention to prevent or reduce the onset of mental comorbidities, and we have to find out which factors are of greatest influence, and the ones that can potentially help with early prevention, in particular the self-concept and the self-determination of individuals. And the last thing that he is interested in, and we're all interested in, is how that also can impact and reduce costs to the healthcare system and the society at large. One of our graduate students, Uzma Williams, is currently doing a sort of small-scale study in one of the children's treatment centers in Ontario. And she built her evaluation of a program on the Anderson model, where the environment, here the healthcare system, is evaluated in terms of the outcomes, the perceived health and the health status and the consumer satisfaction. And this is a first study to get a handle on if this would work. I think we are at the point now that we have the outcome measures, so we have developed the reliable and valid outcome measures, so we can report on health status, on participation levels, and consumer satisfaction with the measures called the measure of processes of care. And we are now looking into characteristics of the population, characteristics of the service provider, as well as healthcare or health behavior, including visualization techniques. And I think that's another topic that we may want to discuss, how CHEPA and CanChild can come together. With that, I'd like to thank you for your attention, and I'm happy to take any questions. Thank you.
Happy to start with a really silly question. So you said that there is a transition of age 18. Is that for clinical reason that you, for instance, cannot follow your patients when you turn 18? Is there a good clinical reason why all of a sudden you become totally incompetent, or is there any other kind of institutional reason?
Yeah, it's a system issue. So there are two types of transitions: age-driven and system-driven, and this is a system-driven transition. So there are models in different places that is age-driven, that you say, okay, I look as a clinician when the individual is ready to make the transition to adult services, and that could range between maybe as early as age 16 up to age 25, for example. And there are arguments for and against, I guess. In Ontario, it's very strict, and it's basically the mandate of the Ministry of Health. And I'm sure there are, when we worked with the Provincial Council for Maternal and Child Health, it was very clear that that was a given for various reasons. I think it's just policy making, and I'm sure it has to do with budget as well.
Is there any healthcare system around the world where in which it's different? Or?
Yeah, there are other models. For example, in the UK, there are some models where they have so-called youth and adolescent clinics more than that age range, 16 to 25. In the US, you see some development that pediatric hospitals sort of continue to provide care to individuals with child-onset conditions. So basically, a pediatric hospital becomes also an adult hospital. I think because that's also how they deliver services and get paid. It doesn't change the sort of outcomes as far as we know right now. So the different models, there's no single answer. And in the end, I think what we learned from our research is that in the end it's all very individual. And so you have to look at some individuals do really well at an early transition to adult services, where others don't, and we have to find out why and how we can support them. But there's no clinical reason.
Thanks, Dr. Gorter. That was great. My name is Evan Denberg. I come at this same problem from the childhood cancer world.
Okay.
And so have noticed issues with the specificity to which they apply to kids with cancer. What I really like for what you did and what CanChild's doing is taking a step back and looking at the commonalities across disease entities, and they're looking for the opportunities for cross-pollination of ideas across traditional silos.
Yeah.
I have a couple of questions. One, I wonder about, and you just mentioned individuals and the need to continue to maintain a lens and focus on individuals. I wonder the degree to which, with broad frameworks like this, you lose the specificity that is requisite for good care for kids with chronic disease within each discipline. So, there's a lot of very unique issues for kids with cancer who are adolescents, young adults, and transitioning to adults. But and one of them, you think maybe they'll do some care.
Yeah.
community hospitals versus regional cancer centers versus pediatric centers. The other thing I suppose is, so in kids with cancer, because of the agents we've traditionally used, when taking a life course perspective, you know, some of the late effects of therapy are quite late. They're not 2 years later, they're not 5 years later, they're 30 years later. And we still don't know the burden on the health system, and we don't know how to properly equip the system to respond to that. And same thing with new agents where we have targeted therapies, we don't know how they're going to impact growth and development. So I wondered if you could comment on those two things. One, the specificity, understanding specificity across when using broad frameworks, and two, how to model out that far. Yeah, like for stuff.
That are the critical questions, I think, to answer. So I think there's specificity for sure, right? And even within the group that I work with developmental disabilities, including spinal bifida, who have need for very specific services like neurology, for bladder control, where cerebral palsy may not have that specificity. But if you look at that's very limited, or not limited, I should say, but it's very focused on health and health care. If you look at functioning and in the community and in society, I think there are more commonalities, as you mentioned. And I think that part is also following, to a large extent, the diagnosis, which doesn't make sense to me. That, for example, there are specific diagnoses that come with pockets of funding, and the assumption that it's very specific and would help in general our society to thrive, or people in our society to thrive. But maybe for a very few, but not at large. So we have to rethink that. So if you think of the education system, for example, and the social system, these are across conditions. And that's what we found in our knowledge synthesis, and that's why we went that route for recommendation. Sorry, your second question.
It's just about modeling out very far.
Yeah. Yeah. Well, that's the knowledge. That's what the knowledge we don't have, right? I think it's across conditions. Since the 1970s, we see now people more and more surviving into adulthood, similar to the cancer population, but we have hardly any longitudinal studies. I would argue that would require specific service people who know what they have to look for, because that's another challenge of once children leave the pediatric healthcare, basically they go everywhere, right? And you don't have, it's very hard to keep a good oversight where to go, what the issues are, and so forth. So then a specialized center would probably be more equipped to maintain that relationship, to look for late effects, for example, of cancer, and to reform from that. So yeah, I would argue that would, for sure, we need that, because our developmental, our curves, our trajectories are all ending at age 8 years. Yeah.
This sort of blends, I guess, Avi's and Michelle's question. I'm interested, as Avi knows, there's aftercare clinics for kids with cancer. So even though they reach the age of 18, and as you said, they go out and are cared by a variety of individuals, they're meant to have annual visits back with their care team once they were a child, or once they reached 18. So I guess my question is, are you, and this sort of ties into what Michelle was asking, is it center specific, or are you prohibited? Like, what kind of follow-up is there with them? I don't know how the aftercare clinics work. Yeah, but is it? Do you
I think it's pretty unique for a condition like cancer. Yeah. They are really at the forefront of that type of organization of care and research. For other conditions.
So you don't have something like that. Would you be? Are you? I guess what I'm asking is, are you prohibited from doing that? would the ministry allow you to do that? Like I said, I don't know how they set up the aftercare clinics.
It's very unique here, actually,
Yeah.
for aftercare, like the fact that the doctors here can see the kids until they're not kids, until they're 40,
Yeah.
is not common. In Toronto, the aftercare clinic ends at 18, and they go across the street from London.
Oh, okay.
So there's actually an open question. One of the studies we're doing now with population health databases like ICE is looking at the kids who are treated in aftercare at a pediatric center versus community health centers versus regional cancer centers, and looking at focus of care impacts adherence to survivorship guidelines. As you say, cancer is one of the only conditions where we do have 30 years to 40 years of late effect status.
Yeah.
Yeah, I wonder if that's manageable, right, for all conditions. If you look at the numbers, that's something to think about at the policy. The other thing is more from a developmental perspective. I mean, everyone leaves high school, right? And we don't stay in high school forever. So why should we stay in pediatric care or an extension of pediatric care? I mean, the message we're giving is now that people have to be prepared for an adult life. And you could say that there are challenges with the adult healthcare system welcoming these people, but this is the new reality. And one argument I would make, but it's a personal note, I should say, is really that to build capacity in the adult healthcare system and in the communities, and to make connections between the two worlds, because that's the other missing link. That there are, I mean, adult healthcare providers are not bad people. They want to take care of these people, but they often don't know what the issues are, what to look for, how to take care of them, and they don't have the resources. Well, that comes back to policy.
Yeah. I'm just thinking even in terms of my experiences at the Children's Hospital at Mac, and their aftercare clinic, they have so many kids now that they have a separate team just for aftercare. So even just human resources, they have a physician, that's all he does, and he has a nurse practitioner, and that's all.
That's what we're going to have like 50 for the world.
Yeah.
They're totally overwhelmed.
Yeah. So, right, it comes back to how do you organize it. Yes, please.
Hi, I was wondering, doing some work with the adult world of the evil adult world of international developmental disabilities. I work with Scotiabank Chair. We have a couple grants right now where we're trialing methods of better support in emergency departments and primary care for adults with developmental disabilities. But I'm specifically interested in the levers that you're dispensing from government. Like, what is, from the MCYS side of things, the Child and Youth Services side, what is it they seem to be attending to in the field? Like, I know ALC days, for example, is a big deal in the adult world of intellectual developmental disabilities. And we do actually, I think there's an opportunity, we do have data now through the ODSP system to be looking at long-term health impacts, which I think we could maybe do some of that linking. I don't know. I think it's fairly complicated. But anyway, there's a possibility for that modeling. Yeah, I think there's a possibility. I think, anyway, but I'm just curious about the policy levers. Like, where is the interest and sensitivity in MCYS now when it comes to it? What seems to be driving them?
So I think, I'm not the minister, although I did hear her speak a few weeks ago. And I heard her saying two things that I took away from that meeting, that although, to answer your question first, is that they are most challenged by all the young children requiring services. So there are huge wait lists, and that's a huge issue and pressure on the families and the services. So they have to work with that. That's one of the main issues, and to address that issue. So, right, young children are not diagnosed, for example, if they have behavioral issues or issues with their social communication, and may have or may not have a diagnosis of autism, right? That are the issues. And if you are diagnosed with autism, you're on a wait list to get services and so forth. So that's huge. But the minister also said that that he has an understanding that transition is becoming an important issue for the needs of children youth services. So I could say that. And the other thing is what I found interesting, which relates a little bit to our work, is that in the past or so far, the services have been really service-driven, and also the funding would follow service organizations. And they're working to a new model that will be more data-driven and outcome-focused. And I think that would be something we could potentially learn from the US too, that in the educational system. I think the literature that we base our knowledge synthesis on has a lot from the States, because in the educational system, right, there was by law, there was the need to report on outcomes such as employment and how young people are doing after high school. We don't have that in Canada, and we don't have a system that drives that, and we don't have the outcome measures. So I heard the minister saying that that's the way to go, and I think it fits very well with our thinking, that we need, first of all, to develop the outcomes, and to me it would be beyond the traditional and normative ones, because they are not so helpful in the end. They don't contribute to quality of life. Right? You can be married and still be depressed and anxious because it's a bad marriage, right? It's a bad relationship. But you can have a very supportive relationship, but you're not married. So that are the type of things you have to think.
So,
yeah. Michael, sorry. You're
no,
I really enjoyed your presentation. My name is Young. I'm a first-year student in the PhD program of policy.
Yeah.
So I have to say that I'm not really an expert in this area, so it was kind of eye-opening to hear your presentation. I was hoping to get some more background information as to why, like in terms of delivery of service or type of service provided in pediatric hospital versus adult hospital. Because it seems to me that there's almost a discontinuity. It's like once the person reaches 18, they're forced to go to the adult hospital.
That's right.
And is there like any big difference in terms of type of service, delivery service?
Yeah.
I mean, because I think that's a very naturalistic experiment, and you can actually narrow down what are the factors that's causing the negative outcomes, right? And my second question is, I guess you kind of mentioned in your presentation that you're projected to have more burdens in healthcare resources in terms of money and benefits. And your presentation kind of indicated that you could potentially save money in the future. And like, I guess that's not a good enough evidence to convince the policymakers to provide more funding. But like, how do you deal with any interest groups or other interprovincial members that kind of help those issues together? Or I guess my subsequent question is there another province that does similar work, but that shows like different outcomes in different organs?
Okay. I'm aware of the time. You asked two questions.
Yeah,
until I ask for answers. To start with the first question, there's a huge difference between pediatric healthcare services and adult healthcare services. And one of them being the most sort of obvious one is that by nature, children don't come by themselves to the clinic, so they come back with their families. So you have to have a family-centered approach. And there are differences in the way pediatric services do it, but it has to be with the families, and that's a huge support. And basically you build on the strengths of the family too. So yes, in child they have some challenges, but at the same time you look for strengths in the family and support. The adult healthcare system is very person-centered, so on the person who has it, and is very reactive. So you probably wouldn't go on a regular basis to a physician unless you have pain in your foot or so, and you find a doctor who knows a lot about foot pain. He will fix it, and then will send you away. And that's it. So there's no continuity. That's great for quick things that can be fixed. But the issue in these conditions are that they are chronic. So we need a chronic healthcare model, and that's lacking. The way the system is set up, as well as how healthcare providers are trained. But also there's no incentive to for example, finding a family doctor for some of my patients with developmental disabilities is sometimes hard. And again, it's not that they don't want to, but the clinic is already full, they have lack of time, there's no big incentive to, for example, see a patient longer than 10 minutes. Well, think of the patients that need time to get from the waiting room into the clinic and need time to talk and so on. So that are those challenges. Yeah. How much time do I have?
I think 5 minutes is what we
Okay. I don't know what everyone's commitments are and so forth. Sorry.
Is there just pretty much is there any similar or different interprovincial programs that try to approach this?
Yeah, that's a good point. I think in other provinces there are some models where there's some more flexibility around age 18, and that might be good for comparative studies. We haven't, so as far as I know, we haven't done it, but that would be a great idea to look into that. I think the other challenge is that we need to work more together. So in terms of the transition issues, I mentioned that the literature, but also the approaches to address these transition issues are very siloed, so very condition specific. So even in our own hospital, right, I do my thing in developmental disabilities, developmental pediatrics, and in other clinics and do other things, and we have to bring that together. But also, if you look provinces like in Ontario, the 6 academic health centers, pediatric health centers, don't have one approach. And I'm very excited that as part of the new CHR's 4 initiative, we were able to get some funding, and we will have an inaugural meeting on November 14th to bring together people interested and experts in transition across the 6 child health centers, and to find out what the common issues are, and to develop a research agenda so that we can work together and address this issue. We're all in the same sort of mandate of the Ministry of Health, so we're all right at that system-driven age stage that's an effect. How do we go about it, and how can we come up with approaches? One of the things is to look into what we call transition readiness, so to look into the level, the extent to which the individual child or teenager, adolescent, is able to take charge of his or her own health. Because that comes back to your first question, is in the adult healthcare system, it is assumed that an 18-year-old is able to take charge of his own health, which is not the case. So we better sort of assess that in a good way, and then see what supports we can put in place, or education programs to help them to get there where they need to be.
And there's one last piece that you can ask and answer in 2 minutes. The challenge is up there because you had one last question, I think, right?
Yeah, that's all. Okay.
You're okay? Well, thank you, Dr. Gorter, for coming.